At ASCO 2025 GU, we presented a study looking at PARP1 mRNA expression in prostate cancer and its relationship to outcomes and also potentially sensitivity to the PARP inhibitor olaparib. So the design of the study, there were three parts. The first part, we used a large database of transcriptome information from Decipher Veracyte. And what we did was we took about 52,000 patients who had the Decipher Veracyte RNA test performed on their primary prostate cancers. And we looked at 16 PARP enzymes at the mRNA expression level to determine whether high or low expression of one or more of those 16 PARP enzymes predicted adverse outcomes such as extraprostatic extension, seminal vesicle invasion, and lymph node involvement. The second part was we looked also within the Decipher database at three cohorts of patients on whom we had information about metastasis-free survival outcomes. And we asked the question, does the expression of one of the 16 PARP enzymes at the RNA level associate with metastasis-free survival in those three data sets? And then the third part was we took data from a prospective clinical trial giving patients with biochemically recurrent prostate cancer olaparib as a monotherapy. And we used their prostate biopsy PARP1 and other PARP enzyme expression to determine if any of those would be predictive of olaparib response in the biochemically recurrent setting in that prospective trial. The first thing that we discovered is that when we looked at approximately 52,000 primary prostate tissues on which we had mRNA expression, we analyzed 16 different PARP isoforms, PARP1, PARP2, all the way up to PARP16. We found that 4 of the PARP enzymes are associated with worse adverse pathologic features if they are elevated, and the 4 that portend a worse adverse pathology are PARP1, PARP2, PARP8, and PARP14. You might have never heard of some of those PARP enzymes, but they do exist. On the other hand, there were 2 different PARP enzymes, specifically PARP6 and PARP7, where higher expression of those 2 actually portended a more favorable outcome, such as less extraprostatic extension, less seminal vesicle invasion, less lymph node involvement. The other thing that we did was we correlated those PARP enzyme mRNA expressions with Gleason grade, and we found that PARP1 and PARP2 enzymes, when their expression is higher, there is a greater chance that that prostate cancer will have a Gleason grade group 5, in other words, Gleason sum 9 or 10. And again, with PARP6 and PARP7, it was the opposite. Higher expression of PARP6 and PARP7 was less associated with the high Gleason grade 5. The most common biomarker that is used for risk stratification and therapeutic decisions when it comes to PARP inhibitors at the moment is the homologous recombination repair gene mutations. These are genes such as BRCA1 and BRCA2. And what we do in this case is we sequence and analyze the gene for alterations, but we're not looking for levels of expression of the gene. And as you may know, inactivating mutations of those HRR genes, especially loss of function mutations of BRCA1 and BRCA2, particularly BRCA2, is the best biomarker that we have at the moment that predicts a favorable response to PARP inhibitor, either used alone or in conjunction with a androgen receptor pathway inhibitor. So in this case, what we did actually, which answers the question about what distinguishes this biomarker, The first distinguishing feature is that we are looking at the expression of a transcript. We're not looking at a genetic mutation in a gene. And the second thing that distinguishes it is that this does require the assay to sequence or quantify mRNA expression, not just DNA sequence alterations. So a lot of clinical grade assays that you could order in the clinic, they would sequence the genes themselves, but they would not necessarily give you the level of a particular transcript. So this requires an extra analysis, not just of the DNA, but also of the RNA to be able to interpret and report the expression level of these PARP transcripts. This study does add to what we already knew, but it complements it, I would say. What we already knew is what we discussed earlier, is that patients that have genetic mutations, especially inactivating mutations of the HRR genes, especially BRCA1 and 2, are the ones that we have known for several years are most responsive to PARP inhibitors. What we discovered in this analysis, which supplements what we previously knew, is that a high level of PARP1 enzyme at the transcript level may also predict favorable response to PARP inhibitors. And we made that discovery using the 40 patients in our prospective clinical trial of olaparib as a monotherapy in patients with biochemically recurrent prostate cancer after radical prostatectomy. So these were people who had a curative intent prostate resection. Their PSA initially went to 0 and eventually began to rise after that. And then these patients were treated with olaparib as a monotherapy in the absence of any hormone deprivation. So they were not getting ADT or leuprolide. And in those patients, we were able to go back to the radical prostatectomy specimens and analyze the expression levels of all 16 of those PARP enzymes. And what we found was that the patients that had the best response to olaparib in this setting were the ones that had the highest PARP1 expression levels in their prostate tumors or prostatectomy. At the moment, PARP1 expression is not integrated into clinical decision making because there is no validation of this biomarker and there's no commercial platform for this yet. So at the moment, we are still using HRR gene mutations to do that. But in the future, my hope is that the mRNA expression of PARP1 will complement the genetic mutation information. For example, we know that not all patients with BRCA2 mutations respond to PARP inhibitors, but it's possible, and our data does hint at this, that if you have a BRCA2 mutation plus a high level of PARP1 enzyme, those patients may respond better than those that have BRCA2 mutation and low level of PARP enzyme.